Everyone. This is Stephanie Arnold-Pang, Director of Policy and Communications here at the National Coalition of STD Directors. Welcome to our webinar, How Can We Measure Sexual Health? A Perspective from the Sexual Health Rankings Project. We are glad you can join us today for this important topic. Just a few items of note before we begin. All participants are in listen-only mode, so please use the chat function to the left of your screen for any questions you might have during the presentation. In addition, this call is being recorded, and both this recording and the presentation slides will be available after the webinar. With that, I would like to now turn it over to Bill Smith, the Executive Director of the National Coalition of STD Directors.
Hello, everyone, and thank you so much, Stephanie. Good morning, good afternoon, depending on where you are, and thanks for joining us today. Let me begin by extending my thanks to my colleagues at NCSD, and in particular Stephanie and her team for pulling together today's webinar. It's wonderful to have communications capacity at an organization that we're able to pull things like this off, so thank you, Stephanie. I'm just going to briefly say a few words and then introduce our presenter today. So I think as you'll see on the presentation slide in front of you there, NCSD has been increasingly focused on encapsulating our own work within a sexual health frame, including that means changing our tagline for our organization about 2 years ago to promoting sexual health through STD prevention. Also earlier this year, we held what I thought was a really strategic meeting among various partners and states about what the development of sexual health plans and frameworks looks like in states. And I think we learned a lot from that meeting, including from the federal perspective, national perspective, down to the state perspective, about the ongoing challenge of what sexual health means, but perhaps even moreover, how do we measure it? So if we're moving out of a specific focus on disaster aversion and just measuring, prevention of certain diseases or teen pregnancy, what do additional measures look like to determine if these renewed efforts and reframed efforts around sexual health are making a difference? And I will tell you that when I first read Sexual Health Rankings Project, it made me think in really new and creative ways, and I think our hope at NCSD is that after the webinar today, you'll take away some of that sense of wonder and new thinking and perhaps even more. So with that, let me just introduce our speaker today, who is Martin Downs. Martin is the founder and principal of Variance LLC, a research and communications firm dedicated to promoting sexual health based in Lebanon, New Hampshire. He has over 13 years of experience as a journalist and public health professional. He's a graduate of the Master of Public Health program at the Dartmouth Institute for Health Policy and Clinical Practice. And I will just say that it's been a great pleasure getting to know Martin to date and learning a little bit more about this project. And we're excited, Martin, and profoundly thankful for you joining us today. So with that, I'll turn it over to you.
Okay, thanks, Bill. And thanks to everyone at NCSD for hosting this. And I have to say also it's really exciting that so many people are interested in joining the webinar today. I think Bill gave a great introduction, and here's my title slide, which you have seen and are briefed on. Stephanie, you're going to be just responding to my verbal prompts to forward the slides. So with that, you may go ahead and advance it. So I'll give you a little overview of what I'm going to be speaking about. I have to confess this is my first webinar. I've done a lot of speaking, but normally I'm working on with the constraint of 15 minutes to present. So I have wished for the opportunity to be expansive, and now I should be careful what I wish for. So I'll spend a little bit of time on background, go over the 2012 Sexual Health Rankings results briefly. I expect that most of you have seen them on the website. but we'll just do a quick review of that. And I would like to spend most of the time discussing measuring sexual health, talking about what is sexual health, talking about composite indicators, and the process that I'm using to build this composite. Then we'll take some questions. So if you want to go ahead whenever you're ready. On background, go ahead again. Bill did a very nice job introducing me, and the only thing I have to add to that is that I started Variance last year, so it is, if you want to advance again, this is where I'm speaking to you from. Second floor over to the left, that's my office. Go ahead to the next slide. Variance, I started Variance as a vehicle for pursuing the Sexual Health Rankings project, but as an enterprise, this is, Sexual Health Rankings is the inaugural product of Variance, and this is the kind of thing that I'd like to do. Promoting sexual health by the idea of pursuing novel investigations, really coming up with interesting ideas and questions about sexual health, and then pursuing investigations independently and in partnership and/or in partnership with other organizations, and then turning the insights gained thereby into information products to disseminate them and to create things that will be valuable. And as an MPH, so I come to sexual health with a public health, I believe in the public health approach, and so that's how, that's the principles on which I work. And then I think it's important to also mention that that I want to emphasize positive approaches to sexual health. If you want to go ahead to the next slide. So the overall goals of the Sexual Health Rankings project, in part, it's a scientific inquiry. It's a research project, and it's a public health question. What is public health surveillance of sexual health? How is it being done? How could it be done better? And then to look at the U.S. states, which I think is important. That level of measurement. I think that states are meaningful geographic and demographic units, and my research hypothesis was that there would be variation among the states. But in so doing, the process of doing this is a way of promoting a positive wellness-focused approach to sexual health. And it has the effect of normalizing, prioritizing discussion of sexuality, and introducing discussion of sexual pleasure, which has, it tends to be an elephant in the room, and to really include it and bring sexual pleasure into the discussion. The sort of the why, it's people have engaged in sexual activity, approach sexuality. Part of it is because they like it, and you want to go ahead and advance. So objectives for the project for the first edition, simply to build the Composite Index, get the website made and put the results up out there on the web, and then to get feedback. I think the little diagram on the right shows that I really intend this to be a cyclical, iterative process of building, disseminating, getting feedback, and continuing to develop and improve the product. If you want to go ahead. A timeline for background. I started working on this in May of last year as a speculative kind of thing. It was a question that had been on my mind. I started to investigate whether doing this to build this composite index could work if it was feasible, and then started to really get engaged in it more and more, and saw that it could be done. And so a couple months later, by September, I was ready to go all in and start variants. And after I had completed a first draft of the research paper, I realized that doing a concept paper, a research paper was not really enough. And also looking at the preceding examples of this kind of thing, namely America's health rankings and county health rankings, that it was important to include the outreach part of it as part of the project. That the so what do you do with this? Why how are you going to use it? And I realized that as an individual, that I did not have the expertise or capacity to do everything on my own. And I reached out to Megan Andiu at the Center for Sexual Pleasure and Health in Rhode Island to see if she would be interested in partnering on it, because that's just exactly the kind of thing that she does and that her organization does. And we agreed to partner on it about a year ago. And if you want, I had my goal was to get it launched on the web by the end of 2012. I just made that deadline, and there was a soft launch of the website on the 28th of December. Waited till after the holidays to do an official release. If you want to go ahead to the next slide. Just a couple of bullets about the roles of the two organizations. I do the research, project management, and the CSPH has provided people and done a lot with outreach. Megan is always on the road. She does a college sexual health, college sex tour. She's constantly speaking to large groups at colleges and universities, and she includes the rankings in those talks. If you want to go ahead to the next slide, I want to name a couple of people, a few people. Megan, and so the CSPH provided me Alicia Gauvin who was an intern for the CSPH at the time, and Alicia was really provided critical help in actually getting the website built and up on time, and then afterward did a lot to develop the social media platforms that we've been using. Danny Zions is a MPH student at McGill University, and she spent her summer working on sexual health rankings as my intern, and continues to be available on a volunteering basis. And so all terrific people. I wanted to mention them by name. If you want to move on to the next slide. there's Megan at one of her talks talking about the rankings in Tennessee. Next slide. So the results. What I put out there in 2012, go ahead. There was a website and there was a research paper. Both the research paper is available for download on the website as well. Go ahead. So, quick overview. The 2012 edition of Sexual Health Rankings included 50 U.S. states and the District of Columbia. The states were ranked 1 best to 51 lowest or worst by their composite score. The Composite Index includes 26 individual sexual health indicators. It was used only existing publicly available data. There was no primary research. These were all data that could be obtained publicly. And there's an equation, if you like equations, for the composite. The composite score is the sum of the weighted standardized Z-scores obtained when aggregating after aggregating all of the separate indicators. So next slide. Here are the rankings. If you haven't seen them before, the top 10. And the bottom 10 is the next slide. And you can go ahead. And there's a map. Light blue represents the higher scoring states, and progressing to angry red for the lowest scoring states. It is a complete coincidence. People bring this up all the time, that that blue, red state, blue state thing. Blue is nice, calming, positive color, and red means caution. That's not a political map. Go next slide. So this is where I want to spend the bulk of our time, talking about measuring sexual health. So what is sexual health? How am I defining that? You want to go to the next slide. From the inception of the project, the project is based on the World Health Organization's definition of sexual health. And that definition was really the inspiration for the project, because it is so holistic and encompasses so much that there are so many things in there. I've started to wonder if it would be possible to how to measure them all. Could they be measured? Are they being measured? So I'm not going to read it out loud to you, but it's a positively stated definition about well-being, not merely the absence of disease, dysfunction, or infirmity. It includes having pleasurable and safe sexual experiences, and free of coercion, discrimination, and violence, and emphasizes also the human rights. It also contains these nested terms, which I've underlined, and if you go to the next slide, I'll talk a little bit about that. I think, kind of cleverly, they have additional definitions of those terms. So, okay. So, sexuality is a central aspect of being human, and it covers a vast area of human experience, and touches on all aspects of life and health. Next slide. Sexual rights. These are the things that that people have a right to, and they help them kind of inform what things about sexual health ought to be measured. If we want to continue to the next slide. So that's a lot of verbiage, and for the purpose of measuring sexual health, what I did was to distill all the language, to break out the syntax, and find the core elements in that definition. And the thing is, there are other definitions, and I want to give. I didn't put a slide on it, but about it. But I did want to mention the National Coalition for Sexual Health has put forward another very good definition, which is, and I'll quote it: "Being sexually healthy means being able to enjoy a healthy body, a satisfying sexual life, positive relationships, and peace of mind." A lot less wordy than the World Health Organization definition, but I think that it still contains these core elements. So the first being autonomy in having autonomy in one's in being able to control one's sexual experiences and behavior. The ability to choose if and when to procreate, freedom from discrimination and violence based on sexual orientation, gender identity and expression of sexuality, sexual pleasure and satisfaction, and we're going to talk more coming up about those terms, pleasure and satisfaction. And then, of course, even though the World Health Organization definition sort of says it is not just freedom from disease, dysfunction, and infirmity. Those are still part. Those are still part of sexual health. So, not to negate those. Those are core to sexual health as well. Next slide. I want to talk a little bit about composite indicators and what they are, why they're useful, before we dive into the nitty-gritty about them. If you want to continue to the next slide. A composite indicator or composite index, the terms are used interchangeably. The idea is that a composite indicator measures a multidimensional concept, a big concept that cannot be adequately captured by a single indicator. And what it is a mathematical combination of a set of individual indicators, creating a single index and a single statistic based on an underlying theoretical framework. And the underlying theoretical framework is very important. It's the basis from which you start. You don't find indicators and then look at them and say, that we have all of these indicators. Let's say that they are measuring something. You start with defining the concept you're trying to measure first, and then find the indicators that measure it. Go ahead to the next slide. The methodological underpinnings of all of this. I just mentioned America's health rankings and county health rankings have, in the United States and in the field of public health, have done a lot of work that this builds on in creating a composite index and ranking of health, population health. In terms of the actual calculations and the procedure, I've drawn a lot from the work done by the Joint Research Center of the European Commission and Organization for Economic Cooperation and Development. It's actually there's been a lot of work done and continuing to be done on developing composite indicators in the field of economics, and it does carry over to public health as well. There are some differences, but it is largely applicable, and I will be citing a lot of things from OECD as I go on. Next slide. The pros and cons of composite indicators. They are really useful, but they are not perfect. They have the advantage of being able to summarize a really complex multidimensional concept. And if you just think back to the slides that I showed you, the World Health Organization's definition, it's a very big, sprawling concept, and there are many indicators that measure aspects of that. And there are so many, in fact, that it can be difficult to get a handle on all and to get a grip on all of them. And what a composite indicator can do is really, organize them and simplify them into a single statistic. And that enables comparison and ranking. I say entities, it could be countries, it could be states, it could be cities, it could be counties. But with that sort of condensed, distilled statistic, it allows you to make those comparisons. It's also a communication tool. There is a lot of scientific validity to composite indicators, but one of the main things, one of the main reasons for doing them is really to get people talking and arguing and really thinking about the thing that you're trying to measure. The cons. They can be misinterpreted, they can be misleading, and they can run the risk of oversimplifying. And if taken very seriously, and they can policy can go astray. And that building a composite indicator is not there's a lot of math, but it's not an objective process. There are lots of judgments involved, and those judgments affect the results. We'll talk more about that as well. So next slide. So here is what I've been doing. If you want to continue to the next slide, dive into that. Okay, so here is a diagram of the general overall process. Starting with the theoretical framework, as I said, moving on to selecting the indicators, then examining the structure of the data, determining how the individual indicators are to be weighted to create composite. That's very important. And then testing the composite to assess the robustness of the indicator, and making connections with other indicators. That's what do you do with it now that you have this great thing that you've built? What it allows you to do lots of further analysis and becomes useful in continuing to investigate the concept, and can also continue to provide feedback to improving the design and making it better and more useful. So next slide, please. This is showing the work to date. In the first edition of the rankings was not really complete. It didn't really. I think the multivariate analysis, the examination of the structure of the data set, underdeveloped. Did not get into testing, doing the uncertainty and sensitivity analysis, and it was left as well. Here is this. What do you think of it? So those are things that we're working on now. I just wanted to point out that if you've read the technical report of the first edition, you may see that those things are underdeveloped. So it was focused on building the framework, looking at the indicators, and then developing a system for weighting them, which we'll talk a little bit more about. But you can go ahead. So we're going to take these steps one at a time. The theoretical framework defines the concept to be measured, specifies the key elements of the concept, and identifies categories of indicators. So it helps to think of it in terms of a filing system. I don't know. I do a lot of filing, and sometimes having different folders labeled different things makes me think about which folder does this go in. Is it a receipt? Or is my DirecTV a utility, or is it or something else? What does that say about my gas and electric bill if they're the same as my TV? Is it that essential? So it makes you think about where you're going to put that measure, and helps organize things. So indicator selection comes next. Actually, before I move on, I think that it was important to me to use the World Health Organization definition, because it wasn't something that I came up with on my own. It was it is propagated widely through multiple disciplines since it was released I think in 2006, and gained wide acceptance. And it is a product of a massive technical consultation involving experts in lots of different fields from all over the world. So I feel like it is something that I can stand on. So it's not just one individual deciding what sexual health is. Next slide. Here is the framework, and showing its sort of nested structure, the World Health Organization definition of sexual health, and the elements defined, and then the categories of indicators. Again, building on work that WHO did, it's breaking it into two larger categories: outcomes and factors, which would factors or determinants of health. Outcomes simply are measures of health status and impact. Factors, adapted work from the World Health Organization on the types of sexual health indicators being categorized as things having to do with laws, policies, human rights, education, society and culture, economic and health systems. And we can look ahead. Oh yes, next slide. I'm going to show you the indicators. We're going to see this a couple more times, so don't rush to read through them all right now. Just wanted to show you how those were organized. So the outcomes measures sexually transmitted infections, reproductive health outcomes, sexual violence, and sexual satisfaction. And those two we're going to talk quite a bit more about are proxy indicators, because there is not a population-based measure of sexual satisfaction in the United States, let alone at the state level and part of an ongoing surveillance system. And factors looked at different state laws and policies, then a couple of indicators about sexual health, sexuality and sexual health education, some sort of measures of pertaining to cultural and societal factors, economics, and then some health systems measures, which are particularly related to the health system in the states, at the state level. So that's kind of how they're organized. We'll move on to the next slide. Indicator selection. So, like I said, the framework informs the indicator selection, not the other way around. There are criteria developed, relevance, availability, and data quality. We can move on to the next one. I'll explain those terms. So the process involves matching indicators to the elements of sexual health. Really doing a is this related, and is there evidence to support that the existence and the importance of that relationship? So the process involves doing a bit of literature review, and in the next slide. Okay, so this is where subjectivity comes in, and ideally, it would be a participatory process and involve consultation with experts from the field and various stakeholders. For the first edition, this is how I did it. If you see these numbers 1, 2, 3, 4, 5, those correspond to the 5 elements of sexual health, and the sort of domino thing shows which elements, which indicators relate to. So I will move on to the next one. We can go back and talk about that more in Q&A if you like. Availability, pertains to the number of different things. Is it available? Are the data available at the state level? Again, these all came from published reports and public data sets. There's no primary data collection, no original surveys done. Really just using the data that are out there and sort of taking a survey of it and finding and using what's available. Next slide. So kind of aspects of data quality. Integrity, do these data come from, are they objective, transparent, are they collected professionally? Accuracy, again, this is similar, were they, are they legitimate? Timeliness is a challenge because and again, another source of subjective decisions and judgments. What time frame are you going to look at? I mean, everybody in public health knows that you never have the data that you want. And so I would love to have 2012 annual data for everything in the 2012 index, but that's not, I had to make some decisions about how far back I could go without, still representing reality, and how frequently those data come out. They are reported. I couldn't use, even if there was a very interesting study, if it was never going to be repeated anytime soon, it couldn't be included in the composite. And then, taking into account issues that could affect the comparisons in the state. So next slide. So here are the time frame over to the right of the indicators this time and where they came from. A lot from CDC, a lot from the Guttmacher Institute and the Human Rights Campaign, and some census data as well, and then some crime data from uniform crime reports. This is all on the web. If I'm going too fast, this is you can all get all of this on the website. Next slide. So challenges or opportunities, depending on how you look at it. Measuring sexual pleasure and satisfaction. Other positive measures of sexual health. There is a gap. There is has not been historically a tremendous importance put on positive wellness focused surveillance of sexual health. And then there are some things, adverse outcomes as well that would be desirable to have or to have better data. And there's always the challenge of having state-level data, because you need very large surveys to obtain a lot of that. So we're going to talk about each of those. Next slide. So how do you measure sexual pleasure at the population level? It's, I think, really an interesting and challenging question. And it's problematic, I think, because what do you focus on? Is there a certain amount of sexual pleasure that is ideal or optimal or excessive or deficient? Is it the frequency of having sexual pleasure? Is it the quality of your sexual pleasure? These are all things you have to think about if you're going to think about measuring it for everyone. And it also, I think, you run into having to make value judgments. And those, sexuality, people's sexuality is extremely diverse. And so I think about if you were to take, say, frequency or ability to orgasm as a measure of sexual pleasure, then you're really saying you're putting priority on orgasmic capacity and making sort of this global statement that to be sexually healthy you have to orgasm every so often or have good orgasms, and I think it becomes problematic. So if you go on to the next slide, that's why, in my opinion, I think it's better to focus on sexual satisfaction. That being the degree to which one is satisfied with the sexual pleasure one has. It's value neutral. And you don't have to think about whether you're going to, whether one person's amount or degree of sexual pleasure is, better than another's, as long as the person is satisfied with their sexual experience. And it's unambiguous. If you are more satisfied, then that is better. If you are less satisfied, that isn't. We would like to see people more satisfied, regardless of what it is that is satisfying. So, next slide. With regard to the use of proxy indicators, I put up a quote there just to defend myself. They actually, in terms of the composite indicator constructing community, proxy variables are not necessarily terrible. Of course, we would love to have a direct measure of everything, but in the case of scarce data, we're going to try to do our best to get something that measures that. The two proxy indicators that were included in the 2012 edition, self-reported health status, adults, good or better, and relationship status, being married or partnered. Next slide. We'll talk about those terms in a little more detail. So self-report. So this is where I have to warn that I did not do a actual meta-analysis. It was a literature review that suggests a number of studies suggest that there is a positive association between health status and sexual satisfaction. So better self-reported health status, increased satisfaction. Fair to poor health is a predictor of sexual dysfunction. I should probably say what these initialisms are. The GSAB was the Global Study of Sexual Attitudes and Behaviors. The International Sexuality Research Study, and the Sex, Romance, and Relationship Study that came from AALP, and of course the National Health and Social Life Survey from the University of Chicago back in the 90s, and the much more recent National Survey of Sexual Health and Behavior. And so also better health status, positive association with frequency of penile vaginal intercourse. But I have to point out that most of these data come from studies of midlife and older adults, ages 40 and up. So may be different for younger people. Next slide. And again, with relationship status, married or partnered, that means married in a traditional, legal marriage, or a member of an unmarried couple, as the behavioral risk factor surveillance survey question has it phrased, or in a relationship. And so, again, noted positive association with sexual satisfaction to being in a relationship, being married, being coupled, being a member of a couple, and with intercourse frequency. So it's a pretty brisk overview of the research, and is what justifies the inclusion of those indicators as proxies for sexual satisfaction. Next slide. So, it's I think it is an open question of whether those are valid proxy measures. They were the best that I could come up with. I think that there's a rationale for including them. They should be studied they should be validated, and further study ought to be done to find other correlates of sexual health. Of sexual satisfaction. A direct measure would be great. If there were a nationally representative population-based survey measuring sexual satisfaction, including physical satisfaction, emotional, in the context of a relationship, in the context of oneself, attitudes and behaviors, that would be terrific. But I think we also have to keep in mind what is feasible in terms of public health surveillance. Is it feasible to include that as a question on the BRFSS? I'm terrible. The BRFSS. And so, it's something to think about. What's practical? If there is a really terrific proxy measure that is already included in national surveillance at the state level, that would be good. So it's something to think about. The next slide. So here is my wish list of things that I would love to have in the Composite Index. Measures of sexuality knowledge, basic knowledge of sexuality and attitude. It would be great to, rather than just have the teen birth rates, to have a measure of intended pregnancies and or births. For a lot of people, having a baby is a positive outcome of sexual activity, and condom use, both for STI prevention and birth control, other contraceptive use. I think there are some interesting questions that could be an argument for including the frequency of partnered sex and frequency of masturbation. I have a book on my bookshelf by Eli Coleman, and I'm just going to reach and grab it. As masturbation as a means of achieving sexual health, Walter Boxing and Eli Coleman. So that it could provide great research data, but it also could be considered as an indicator of sexual health. And then also there's been some great research done on use of sex toys and sexual lubricants, and correlates of sexual wellness. So just keeping an eye on the time. I want to leave time for your questions, so I'm going to move on ahead to the next slide. So in terms of adverse outcomes, we know that the FBI's current statistics on rape are poor. There's a new definition of rape that has been accepted and will be implemented in the future as part of the UCR statistics that may yield better data. The National Sexual Violence and Intimate Partner and Sexual Violence Survey cautions strongly against comparing states, so I stayed away from doing just that. Next slide. And then at the state level, something that I would like to highlight is the use. The YRBS is a terrific resource and source of data but couldn't use it because not all states include sexual health questions on their surveys. And here are some examples. That's something that I think is actionable, and that I think this project can argue for the sort of all states asking these questions on their YRBS. Next slide. So multivariate analysis. This is where I hadn't really the time before to really get into it. And since the launch of the project and the release of that paper, been doing a lot of work on it. And I will show you some things. If you continue to the next slide. So done a lot of work with principal component analysis, which is a way of kind of X-raying and probing the data set to understand its statistical structure. It can be used as a way of culling the data set to include fewer indicators, those that aren't actually contributing to the variance in the data set. And it's also a way of calculating the indicator weights that could be used. It also it answers the question of are you really measuring a multidimensional thing? And if you want to go to the next slide, we'll talk a little bit about that. So here's the result of that. So you have components. Let's see, where do I begin with this? Okay. Components are hidden structures in the data, and if you don't have any, if there are no components, that means that nothing is groups moving together. So you're not measuring anything. You have an uncorrelated data set, and you may not be actually measuring anything multidimensional. So it's good to see that there are multiple components in the data set. So what this shows is component 1 contributes attributable to about 20% of the variance in the data set, and then it kind of goes down from there. So ideally, you'd like to get close to have your components account for something like close to 80% of the variance in the data set. We got kind of close to that. I'll go to the next slide. Probably doing a pretty bad job of explaining this, but this is a scree plot that shows sort of what there are 26 indicators, and this steep drop-off is where the indicators, the components in the data become less are driving the data to a lesser extent. We move on to the next one. So, and I really like this visualization, because rather than having this sort of mental image of data piled on top of data, a list, it shows you the constellation of the data that you're looking at. And I'll go to the next view, and this may make it a little bit more clear. So this is looking at on two axes, component 1 and component 2. These are indicators that move together, and sort of their relationship on component 1 You have these the abbreviations are cervical cancer, poverty, women of reproductive age without health insurance, teen birth on one hand, and women with high school education or above, and health status good or better being negatively correlated with those things. And then on component 2, have AIDS diagnoses, HIV testing, adults that have been tested for HIV, syphilis rates and gonorrhea rates being inversely associated with, correlated with partner status, being married to partner. So next slide. So here are the components, and the way that this can be used as a dimension reduction tool is, each component is contributing 1 and 2 and 3 contribute the most to the variance in the data set, and then these contribute less and less. And the highlighted parts here are the indicators, the correlation of the indicators with that component. I don't know how, it's hard to gauge your interest on the phone in this, and I don't want to run out of time. So I think we can come back to it if you want, and I'm gonna move along. So because weighting, I don't want to run out of time and not talk about weighting. Weighting is very important, and if you'll move to the next slide, I'll tell you about how the 2012 edition was weighted. It was a scheme that I came up with. My primary concern was dealing with the lopsidedness of the indicators. The available data being the sort of disease oriented things being overrepresented, and not driving the index more than the other things that it's trying to include. So this is a way of evening it out. Looking at how much, the decision how much each indicator, what they were related to, and then trying to evenly measure all 5 elements, so that each of the 5 elements had an equal share in the final score. Excuse me. If you want to move on. Excuse me. So again, this shows the weight and juxtaposed with the matrix of what is related, what is matched to what. So that decimal would be, if it's 0.02, it's weighted 2%. And so it sums to 100%. Next slide. There are other ways of weighting composites that can be considered. Equal weighting, just assume that every indicator is equally important. Weights derived from principal component analysis, it does not take into account the theoretical importance of an individual indicator, but it really looks to correct for the overlap in the data of correlated indicators. And then, of course, there's the participatory processes to get a group of experts, stakeholders at large together, and get sort of a consensus on how the indicators should be weighted. And that, is something that I would very much like to try. Next slide. So uncertainty and sensitivity analysis is important. It's resource intensive, and so it wasn't done in the first edition, and it's something that I'm working on now. So if you want to go ahead to the next slide, I'll explain. Uncertainty analysis assesses the effects of the judgment made in the process of building the indicator. And sensitivity analysis assesses how much, to what extent each of those uncertainty factors drives the results of the output. So if you want to go to the next slide, this is a real chart from the 23rd in progress 2013 edition, and this is just one uncertainty factor being the inclusion or exclusion of individual indicators. So each one indicator was knocked out at a time from the set of indicators, and the composite was put together. And so this graph, the upper bar, the upper bracket is the highest score across all of those calculations, and the lower bar would be the lowest score that state received. And then the circle, the point, is the original, the score of all of them together. So it's a good result because it does show that there's a trend that's not all over the place. The effect of including or excluding indicators does not, suddenly change everything, but it does have an effect, which you can see. Next slide. Sensitivity analysis is the reason for doing it is entirely to allow transparency. It's to show, in the end, what the impact of the choices is, and to quantify it. So this I took from the handbook on constructing composite indices. It's an example in that document, and so it shows, for each of the ranking countries in this particular example. So if you were if you were a stakeholder in Norway, you could see the actual degree of the impact of different sources of uncertainty on Norway's score. So if you were with a white there representing normalization, so if you chose to calculate a Z score versus using the minimum maximum method, if you thought that was very important, it was unfairly influencing the result, this chart would show you that, well, compared to most other countries, that's actually true, but in the big picture, it doesn't really change that much. So next one. This is the calculation involved in performing global sensitivity analysis, which is what I would very much like to attempt, but it is resource intensive and time consuming, and still working on it. Next slide. So again, I said about connections. Hopefully, what you come up with in the end is something useful that you can then take and do things with, and that's my hope for, going forward, is to produce a really high quality measure, and then to let it rip and see what can be done with it. And I think that imagine all kinds of great things. Now I think we should take questions.
Great. Thank you, Martin. It's really very insightful and important information. We did have a number of questions come through on the chat function. If you have more, please enter them. We'll try to answer as many questions as possible in the time that we have left together. Martin, I might go back. We had a question towards the beginning of your presentation about the definition of sexual health that you gave verbally that wasn't on a slide. Could you state that definition again and what the source was?
Yes, absolutely. It is developed by the National Coalition for Sexual Health, and that you can probably I don't have the web address offhand, but the NCSD is a member of the coalition, as is Variance. The coalition had a founding meeting back in September, and the group has put out a definition of sexual health as part of the sexual health framework, and I'll read it again. But you can find it on the website. I just perhaps as a follow-up could give a link to it. It's being sexually healthy means being able to enjoy a healthy body, a satisfying sexual life, positive relationships, and peace of mind.
Great, thank you. Yes, NCSD is a part of that coalition, and actually we had a presentation at our annual meeting last week by the communications director of the National Coalition for Sexual Health, so we can also include that in some of the follow-up materials, her presentation and her discussion of how they started their work and came to their definition of sexual health. Moving on to a next question, we've had a number of questions, folks wanting to know how that they might be able to get this, how you might be able to bring this down to a local level. So is there a way that this research could be not only on state level but on the local level? And then also connected with that, is there a way to help have these rankings help monitor programs at the state and local level?
Yeah, those are both really great questions. And as far as you know, going down to finer detail, and again, it becomes a question of you know, the availability of data, and you know, the smaller you go, the trickier it becomes, because then you start to run into problems with comparability and small sample sizes. And I think my answer would be that I think one approach would be to focus on metro areas or big on cities, because that would increase the access to the data that you could use and still have large enough population. I live in a very small town of about 2,300 people, and to rank the towns around me in terms of sexual health, statistically it wouldn't be possible, just because of the size of the population. So, but I think it is important to consider looking at local areas as well. And I don't know, it would be wonderful to have a county level view, but then again, it runs into data questions, and I would probably need some expert advice on what would be possible and what wouldn't. What was that? Was there a next? Was there another? Oh, the other question being using these data to monitor programs.
Right. Right.
And I think that I would like to try to go in that direction. I think however, in order to do that, there would need to be, there would be a lot more rigor, and probably need to have more outcomes indicators in the composite. There are a lot of questions about whether composites can and should be used to monitor short-term policy impacts. And there are conferences on this, mostly in Europe, so it's a good question, and I think certainly want to explore it further.
Great, thanks. We had a question about the term forcible rape. I think you were discussing a little bit of this, but some folks wanted to know how that term came to be, because aren't all rapes forcible, and could you just talk about that term a little bit more?
Yeah. So the Uniform Crime Reports is the annual statistical report put out by the FBI on incidents of crimes in the United States. The definition, until very recently, was written in the 1920s, and rape was defined as so I'm paraphrasing, I'm trying to go from memory here, the carnal knowledge of a female by a male against her will. Okay? And so that is what counted in the national statistics as rape. I believe I think it was in 2011, I could be wrong, that the FBI, the Justice Department, finally got around to rewriting the definition of rape to include not just rape of females by males, but to be a much more realistic and broad definition of sexual assault on a person by another person. Actually in the report, in the 2012 report, if you want to look at what year those statistics under the new definition are going to start to be coming out. But hopefully they will be more realistic and better.
Great, thanks.
Mm-hmm.
Martin, I know we have a lot of questions that have come in. I might do your next slide to give also your contact information. So if folks don't get their question answered, you might be able to connect directly with Martin. We are offering this webinar again, and maybe we can discuss, Martin, you and I offline, maybe to go into depth in some more of these questions that we weren't able to do today.
Sure. And I also want to invite anyone on the line today to if I haven't answered a question to your satisfaction, or you want to just ping me, please feel free to do so. I'm very open to talking about this with folks, and I have benefited enormously from the feedback that I've received since January, and for real, I'm looking to hear lots of perspectives and opinions. So.
Great. Might see if we can get a couple more questions in here. There was a question about what about social determinants of health, so race, gender, class, sexual orientation, education, etc. Was there any discussion of that and measuring social determinants and how that affects your research as well?
Sure. Can you, Stephanie, go back to one of the slides that has the table of indicators on it? Maybe slide 39 or 30, maybe 36 would be better.
All right, let me see. That's not what you're looking for. You're looking for this?
Yeah. Yep.
Okay, great.
Yep. So, one of the things, so in terms of age, in terms of race, basic demographic things were not included as indicators in the composite because chose to focus on modifiable things. So, but in terms of socioeconomic things, kind of go down the list here. One of the, you'll see that it has the 5 bullets next to it. So education of women, which for the indicator it chose women. What was a pretty robust statistic. Women over the age of 25 with a high school diploma or higher education is related, and that's documented in the report to lots of sexual health outcomes. So poverty as well. People in poverty, it's I think very well established that people in poverty experience much worse sexual health outcomes than those who aren't. And basically, I chose those particular statistics because I was able to establish and cite research that supports those connections. And the health insurance and Medicaid statistics, those come from a research report put out by the Guttmacher Institute that shows interesting correlations between health insurance status of reproductive age women and reproductive health outcomes generally. So I think, and then and it fell into these kind of sound like Trivial Pursuit categories, but the society and culture category. Other indices include the percentage or the proportion of representation of women in the legislature as a measure of gender equality. Actually, the UN's Gender Equality Index, which is a sub-index of their Human Development Index, includes that on the national level as an indicator of gender equality, which gender equality is part of the definition and also connected with better sexual health outcomes.
Great. Well, I think we'll move to our last question here. It says, if we wanted to collaborate with you on getting the word out about this on a local level, how can we do that?
Wow, that's a great question. I think talk to me. We also, I put up our Twitter handle there, and I think that connecting with us with sexual health rankings on Twitter is really good. I was fortunate to be invited to speak at the YTH Live conference in San Francisco back in April, and there was there I learned a lot about connecting with audiences on a local level through social media. So that would be my initial answer, would be to work to do that through social media. And I might also add that Megan Andiu is always on the road, and I don't know where she is right now, but she is all around the country all the time, and I think it would be great if she's coming to where you are to engage with her as well.
Great. Thank you so much, Martin. We really appreciate all your information and your help today, and we look forward to engaging with you again on our second webinar on December 6th. And I want to thank Again, all of our attendees today, we had a large group, and as I said, we did have an overwhelming interest for this webinar, so we will be offering it again on December 6th at 1 p.m. Eastern. I will be sending out that information for registration in the link to all registrants for this webinar as well. As I've been saying, this webinar has been recorded, so we will be sending out that recording and Martin's slides will be sent out to you via email and will be available on NCSD's website, which is www.ncsddc.org. And we also have a Twitter handle, which is @NCSDDC. So please follow us on Twitter as well. So thank you all for your time today, and we were very happy to host this webinar.
Thank you, everybody.
Thanks, Martin.
Bye-bye.
Bye-bye.
Thank you. Please stand by.